think there are a lot of signs of dying or deterioration that the care workers can be alerted to or recognise very early. You know, when you've got Fred who just walks to the dining room quite happily for many months, and then, you know, the next month he might need a walking stick, and then, you know, a few weeks later he needs a walking frame, and then, you know, one of the last weeks he's using a wheelchair, and then he's spending more time in bed. They're the classic signs of someone deteriorating and coming to the end stage of their life. And I think if these aren't recognised or documented, it can be very easy to get to a critical point where someone becomes quite unwell quite suddenly. So then it becomes a bit of a crisis, and, you know, there hasn't been any of the preamble or the preparation or the anticipation of what the resident might be needing. So it's very important for care staff to see the signs and symptoms of any illness, but particularly one that might be reversible. And if it's not reversible, then to be able to recognise what is a natural dying. So we can't underestimate the value of what the care staff can pick up on and know about and report and document.
Ultimately, the care workers are the ones that are there in the house, apart from the family members and obviously the client. So they're seeing firsthand, they're hearing conversations, they're seeing moods, they're seeing the response the patients have, the family have.
Care staff see everything, they know everything, because they see even the slightest change. And you try to sometimes put that onto the doctor, and the doctor will come in and none of that's happening.
They're our resource. You know, we're coming in and consulting for an hour here and there. We're guided by the care staff.
I think sometimes people don't often realise how much they know. There are things that you just pick up on if you know someone. And so when I come in, I may find someone at a stage where I can't get any information from them. But the carers, they can just notice little things, and that's very important, because all I'm trying to do when I see a patient is just build a picture. So because I only have a snapshot and they have a bit of a bigger picture, and I take what I have and what they have to try and have a sense of what's actually going on with the patient. So I find people often underestimate what they know, thinking, you know, it has to be framed a certain way, it has to sound medical or whatever way. But actually, even just telling me those little things about a person and what they think is going on is really helpful.
You get to know your clients. You know that they're in a bit of pain, they're not having a good day, the tone of their voice, their eyes, they don't want any breakfast, don't want a cup of tea, their mood, don't want to get off the chair. After you've done your meet and greet and you've been there a few times.
I constantly, in the back of my mind, make sure that from the last time I went there, that they're exactly the same. From the way that they walk or the way they speak to me or can eat their breakfast or make a cup of tea for you, sort of things like that, you constantly watch out for.
I'm always aware of the way they walk. I always observe their feet to see how, if they lift their feet, if they drag their feet, because usually you can tell if there's an issue or if they're in pain.
You really do have to be observant, you know, really look at them. You know, don't treat it just as a job. Really look at them and treat them as a human, and you just pick up little things. Anything that you see, nobody else can see. So if you don't document it, nobody else knows. So you're the eyes and the ears for them. So everything has to be documented. So we will tell the doctors, you know, just this is what's happening, this is what we're seeing, maybe it's this. And our doctors are great, they're happy to listen because they know that we know the residents. And I felt at times where doctors come in to prescribe something and I've sort of said, well, I don't really think that's the problem. This is what's been happening with this resident. I think maybe this might be the problem. He's sort of gone, well, yeah, you're probably right, because they don't know. They're seeing him for 2 minutes, and so they've got to go on what we're telling them, because the residents can't tell them. So quite a few times I've sort of said to the doctors, look, this is what I think might be happening. Maybe this might work. Yeah, and they're quite happy to take that advice.
So the role of the care worker for palliative care clients is as simple as just providing a shower assistance, giving them a bed wash in the bed, assisting with meals, feeding, cup of tea, social support. So just being there in the house, providing conversation or company, as well as respite for the family. So not wanting to leave a patient alone if the family need to go out to have a breather, to have a moment, the care workers can go in there and be in there at that time.
Making sure their mouth's comfortable, all the things that you need because your body starts shutting down. So the care staff assist them to maintain their eye care, their mouth care, whatever it is to make that person comfortable.
I think a typical normal person, when you're lying in bed at night, you would move. You'd move your ankle a little bit, you'd move your hips, you'd roll over. If you're stuck without being able to move, there will be 1 or 2 points in your body that immediately get painful, that would be sore. And typically as a mobilising person, we just move and the blood flow gets there and relieves that pain. For a palliative care patient that's unable to move, that pain just gets worse. So whether they're lying on their back or sitting on a chair, if they're not typically up and moving, you're creating pressure, whether it be on the hip bones, the sacrum, shoulder blades, elbows, really any part of the body, heels especially, can create that redness and pressure area, which can be painful and can go into ulcers if left. Providing that pressure area care is just mobilising them. If they're not mobilising at all and they're in bed flat, you want to be going in every 2 hours and giving them a roll, giving them a rub, typically warm washer and moisturiser, get the blood flowing to the areas that are impacted when they're lying there. They say that for palliative care people that are coming into the end of their life, the most feared thing is that pain, knowing how much pain or discomfort they'll be in towards that end stage. So the most important thing we can do is make sure that they don't have pain at any stage. They shouldn't have pain. It shouldn't be a normal part of getting to that end stage. We should be able to monitor and give them what they need to create that pain-free threshold.
Because they're doing the physical care for the person, they may notice that someone's grimacing a little bit or they're a bit stiff or they're moaning or, and then communicating that to the registered nurse is a really important thing because you want them to be comfortable. In a hospital, it's a lot simpler. You're there, you've got the doctors, you've got the medications accessible. In the community, it's a bit harder. You have to get the GPs out, you have to get the district nurses. It doesn't happen as quickly. So advocating for community care clients is actually getting out there and getting things done quickly and saying that they are experiencing pain, we need to increase this pain medication, we need to create a comfort level for this patient.
I got this beautiful feedback when someone's mother-in-law was palliating and how beautiful the carer was, just sitting next to her, stroking her arm or stroking her hair, and thought that is like beautiful end-of-life care. When somebody has a heart and somebody can see that someone's in pain and feeling uncomfortable, just hold their hand.